Okay, let's dive into a topic that, well, it touches virtually everyone, but understanding how it works, that can feel like wading through layers of jargon. We're talking about modern healthcare management. And specifically today, we're doing a deep dive into managed care organizations, MCOs, and the tools they actually use to try and get a handle on costs and, ideally improve patient quality too. If you find this whole area a bit confusing, maybe controversial, definitely loaded with arguments about profit versus patient care, well, you're certainly not alone. Our goal today is really to cut through some of that noise, give you a clear, concise shortcut to understanding the economic thinking behind it all and the actual management instruments these MCOs put into play.
Exactly. And we're basing this conversation on a pretty comprehensive systemic overview. It's drawn from the world of health economics and healthcare management. The source, healthcare management, managed care organizations, and instruments, really focuses on breaking down these organizational forms and, crucially, the specific management tools involved.
Right. And the central idea, the thesis that really sets the stage, is pretty stark. The source argues managed care became necessary because the old way fee-for-service medicine plus third-party payment basically guaranteed what it calls a fiscal disaster. Essentially, if someone else is paying the bill and doctors get paid more for doing more procedures, there's no natural break on spending, is there?
Seems logical.
And the definition of managed care, or MC, in the book is key here. It's not presented as some single neat theory. It's more like a bundle of widely differing organizational models and management instruments. These get customized and combined to try and manage both costs and quality efficiently.
Which explains why it's so polarized, right? You have advocates saying it's a, quote, necessary developmental step to fix fragmented care. But then critics often see MCOs as basically the commercialization, maybe even the downfall of medicine.
Precisely. And the source gives us really valuable advice here. Don't just paint the whole concept with one brush. You've got to look closely at the individual instruments being used. That's where the impact really lies. Okay, so to understand those instruments, we need the why. Why did the US system in particular shift so heavily towards managed care?
Well, a big part of it goes back to 1965. Medicare and Medicaid being enacted meant the federal government suddenly became a huge payer in healthcare. And almost immediately, costs started soaring because, frankly, there weren't really any cost control mechanisms built in.
Enter policy entrepreneur Paul Elwood. He kind of pinpointed the core issue, didn't he? Cost equals price times volume. And that volume term, the sheer amount of services, was just running wild.
Exactly. Unmanaged volume was the problem. So to control that volume, you first have to tackle uncertainty. The book really leans on two core economic ideas that MCOs are essentially designed to combat. The first is principal agent theory.
Okay, principal agent, how does that break down simply?
It's about situations where one party, the principal, delegates tasks to another, the agent, but they don't have the same information. There's an information asymmetry.
Right, that knowledge gap. MCOs are trying to bridge that gap or manage the risk it creates. What are the key problems stemming from it?
Two main ones. First, adverse selection. This is about hidden characteristics.
Hidden characteristics, like what?
Think about it from the insurer's perspective. The person seeking insurance always knows more about their own health risks than the insurance company does. The classic example is, say, a young woman who knows she's planning to get pregnant soon. She's naturally going to seek out the most comprehensive, possibly expensive health plan because she anticipates needing those services. That's a hidden characteristic that affects the risk pool.
Okay, makes sense. What's the second problem?
That's moral hazard, which is more about hidden action. This happens after someone is insured. Once the financial risk is shifted to the insurer, the patient might overuse services because they're not paying the full cost directly. Or, and this is critical, the provider might be tempted to offer more services, maybe unnecessary tests, because they get paid for volume and a third party is covering it.
Especially those expensive low-yield tests you mentioned.
Exactly. And that is why almost every single MC instrument exists. Things like deductibles, copays, putting doctors on capitation, using gatekeepers. They're all different ways to try and reduce those information gaps and make sure everyone, patient and provider, shares some of the risk and accountability.
Okay, so that deals with the information and behavior side. What about the sheer inefficiency of the system? That brings us to the second theory, right? Transaction cost theory.
Right. Transaction costs are basically all the costs involved in making an exchange happen in a market. The cost of searching for options, bargaining, making decisions, and then, importantly, policing or enforcing the agreement afterwards.
And healthcare seems like a prime candidate for high transaction costs.
Absolutely. It's incredibly complex. Think about a patient trying to coordinate care between, say, 5 different specialists, or the time and money spent arguing with an insurance company over a denied claim. That hassle, that administrative burden, that's a transaction cost, specifically a policing cost. MCOs aim to slash these costs, often through vertical integration, basically, bringing the financing and the delivery of care closer together, sometimes under one roof.
So if those are the big theoretical problems, asymmetric information, high transaction costs, what did the US system actually build to try and solve them? This is where we get the alphabet soup of organizations. The classic model was the HMO, the Health Maintenance Organization.
Yeah, the HMO is really founded on that idea, integration, trying to blur the lines, at least partially, between paying for care and providing care. You see different flavors, staff models, group models, IPAs, network models, all trying to achieve that integration with varying degrees of control and provider setup.
And the book highlights one example as a kind of gold standard for full integration, Kaiser Permanente, or KP.
That's right. KP's huge, something like 8.9 million members now. But their success wasn't just about structure. They made a really key strategic shift back in the late 90s. They invested heavily in quality improvement and unified IT systems, like their KP Health Connect platform.
And did that IT investment pay off?
Big time. It shows the power of managing the process of care. By using their integrated system and data better, KP in Northern California actually saw a 33% drop in emergency room admissions between 1997 and 2008. That's a huge impact.
Wow, 33%, that's significant.
It really is. It's kind of the proof point. Managed care, when it's really integrated and focused on process, can reduce costly utilization and potentially improve outcomes at the same time.
Okay, that sounds pretty good. Highly integrated, efficient, but here's the twist, isn't it? The classic HMO model, which often restricts patient choice quite a bit, faced a huge public backlash. So why did the less integrated model, the PPO preferred provider organization, end up becoming the dominant force in the market?
Yeah, that's the million-dollar, well, probably billion-dollar question, isn't it? PPOs now hold something like 58% of the market share. It really came down to consumer preference for flexibility.
People wanted more choice.
Exactly. The PPO is a kind of compromise. Providers agree to things like utilization reviews, and they give significant discounts, often 25-35%, to be in the network. In return, they get access to the PPO's pool of patients. The patient can technically go outside the network, but the financial penalty, often really high deductibles, sometimes over $10,000 for out-of-network care, strongly steers them to stay within the preferred providers.
So it's financial steering, basically. Keep people in the network through cost.
Pretty much. And we're also seeing newer models emerge now, trying to get better coordination without necessarily the tight integration of an old-school HMO.
Like accountable care organizations, ACOs.
Right. ACOs focus on managing care for specific populations, like the Medicare requirement of at least 5,000 patients. And then you also have patient-centered medical homes, PCMHs.
Tell me more about PCMHs.
PCMHs are really interesting because they try to make the primary care physician, the GP, the true quarterback of care, focus on holistic, coordinated care right at that first point of contact. There was a study mentioned from the Geisinger Health System. They implemented a PCMH structure and actually saw a 20% reduction in hospital referrals and about a 7% drop in overall treatment costs.
So again, aiming to align the money with outcomes, not just volume.
That's the goal, trying to make the incentives match up better with keeping people healthy.
Okay, that segues perfectly into the tools themselves. Let's drill down into those behavioral instruments. The first, and maybe most powerful, is compensation systems. We know fee-for-service rewards volume. What's the main alternative MCOs use?
The big one is capitation. It flips the incentive completely. Instead of paying the doctor for each service they perform, the MCO pays the provider a fixed amount of money each month for every single patient assigned to them, regardless of how many services that patient actually uses.
So the financial risk shifts entirely to the provider.
Exactly. Suddenly, the provider's incentive is to keep that patient healthy and avoid unnecessary services, because every extra test or visit potentially eats into that fixed payment. It rewards efficiency and prevention.
And the source mentioned something like 60 to 80% of HMOs use capitation for their primary care dogs.
That's right. For primary care, it's very common in HMO models. But MCOs realized pure capitation has a potential downside, the risk of undertreating patients to save money.
Ah, right. So how do they address that?
That's where the hybrid model, pay for performance, or P4P, comes in. P4P tries to balance the cost control of capitation with quality. It links part of the provider's compensation, usually bonuses, directly to achieving specific, measurable quality targets.
Like what kind of targets?
Things like positive clinical outcomes for certain conditions, maybe lower hospital readmission rates, or even high patient satisfaction scores. The IAJ California study is mentioned as a good example. Physician groups getting rewarded financially for meeting agreed-upon quality standards.
Okay, so manipulating the payment structure is key. What about direct control mechanisms? Let's talk about selective contracting.
This is pretty straightforward leverage, really. MCOs get to choose which doctors and hospitals they include in their network. They base these decisions on factors like the provider's quality metrics, but also, crucially, their willingness and ability to control costs and follow the MCO's rules. It's especially powerful in areas where there are lots of doctors competing for patients.
Gives the MCO bargaining power.
Absolutely. They can demand discounts and adherence in exchange for patient volume.
And then there's the structural control of gatekeeping.
Right. Gatekeeping makes the primary care physician the mandatory first stop and the coordinator for almost all specialist care. The idea is to prevent patients from self-referring excessively or getting duplicate tests from multiple specialists, tackling that moral hazard piece again. The Swiss Medics network is noted as a successful international example.
And the savings potential from gatekeeping seems huge, based on the studies mentioned. Ranges from 6% up to 80%.
Yeah, that 80% figure definitely catches the eye.
It sounds almost too good to be true. Is that range reliable?
Well, that's exactly the challenge the book points out. Those really high-end savings figures, they usually come from studies where gatekeeping was introduced into a system that previously had zero controls, like pure unregulated fee-for-service. So the potential for reduction was maximal.
Okay.
But in reality, isolating the specific effect of the gatekeepers from other cost controls that are often implemented at the same time, like utilization review or formularies, is really difficult. What we do know is that having that coordination point generally does reduce unnecessary specialist visits and duplicate tests. The exact percentage saving is just hard to pin down precisely.
Got it. Okay, finally, let's look at standardization tools. These seem aimed at reducing that information asymmetry again, getting everyone on the same page.
Exactly. One key tool here is guidelines and clinical pathways. These are basically predefined, evidence-based roadmaps for treating specific conditions.
The cookbook medicine fear doctors sometimes have.
That's the criticism, yeah. Physicians worry it stifles their clinical judgment. But the goals from the MCO perspective are transparency, spreading best practices faster, and actually reducing the doctor's liability risk if they adhere to established standards.
Makes sense from that angle. And the most direct way to standardize, particularly around drugs, is formularies, right? Those lists of approved medications.
Correct. Formularies are explicit lists saying which drugs the MCO will pay for. You might have open formularies with some preferred options, or closed ones where only listed drugs are covered. By doing this, they steer prescribing towards often cheaper generics or drugs where they've negotiated discounts. It limits physician discretion significantly and puts real pressure on pharmaceutical companies' pricing.
So all these tools, compensation, control, standardization, are ultimately about managing that V for volume and handling the uncertainties in the cost equation.
That's the essence of it, yes.
So we've covered the theory, the organizations, the tools. Now the crucial part, what does the evidence actually say? What's the bottom line on costs, quality, and maybe the trickiest part, acceptance? Let's start with costs. Did MCOs actually save money?
On the cost front, the data is generally pretty clear. Managed care tends to show cost-reducing effects compared to traditional fee-for-service. The Swiss studies mentioned, for instance, showed savings potential around 20–30% on service costs. MCOs primarily achieve this by having lower rates of hospital admissions and shorter hospital stays when patients are admitted. They do seem to succeed in controlling that unmanaged volume.
Okay, so a tick for cost reduction generally, but what about quality? That picture seems much more mixed, doesn't it?
Absolutely, it's much less clear-cut. Many rigorous studies find no significant difference in major health outcomes, things like mortality rates or key clinical indicators between patients and MCOs versus traditional insurance.
So not necessarily worse, but not demonstrably better in terms of those hard clinical results.
Often, yes. However, what you do tend to see, especially in the more tightly integrated MCOs like Kaiser, is higher process quality.
Meaning
they might be better at things like documentation, adhering to preventive care schedules, adopting evidence-based guidelines more consistently. So the process of care might be more standardized and potentially better, even if the ultimate health outcome isn't drastically different.
Right. But here's where it gets really tough. Even if clinical outcomes are similar and processes may be even better, the book points squarely at acceptance as a major weakness.
That's a consistent finding. Patient satisfaction surveys often show lower satisfaction in MCOs compared to traditional plans.
Why is that?
Patients value the lower premiums, definitely. But they often report frustration with barriers to seeing specialists, the limited choice of providers, and sometimes feeling like the communication is rushed or impersonal. That perception that the system prioritizes cost over the patient's needs or convenience is a real hurdle.
And it's not just patients, right? Physician satisfaction can also be low.
Yes, particularly when their performance reviews or compensation are heavily tied to economic efficiency metrics. Rather than focusing primarily on clinical quality or patient well-being, that can create tension.
So the big takeaway from the source seems to be that managed care isn't some monolithic thing, good or bad. It's really a set of management tools.
Exactly, it's a toolbox. And how effective or even how acceptable those tools are depends almost entirely on the broader institutional framework, the rules, the regulations, the societal values within which they operate.
Interesting.
In the U.S. context, where there's always been that tension between market forces and social responsibility in healthcare, MC has often struggled with that acceptance piece. The book sort of suggests that countries with stronger social safety nets or social security obligations, perhaps like some European models, might actually provide better guardrails. They might enable a more socially responsible version of managed care to emerge, one that can genuinely balance cost control with a strong focus on quality and patient care. Focusing on the care part, not just the managed part.
So, reflecting on all this, what does it mean for you, the listener, trying to understand this complex system? We've seen managed care as this, intense battleground where business tools, capitation, P4P, utilization review, directly meet the goals and ethics of medicine.
I think the most crucial takeaway, honestly, is this. Whether you're someone designing these systems, working within them, or just navigating them as a patient, understanding the underlying economic incentives is key. Knowing about adverse selection, moral hazard, transaction costs, it helps you see why a specific instrument, whether it's a high deductible or a clinical guideline, was put in place. Every tool is trying to counteract some specific uncertainty or inefficiency. If you understand the mechanism, you can better predict, or at least understand the outcome.
That makes sense. And these managed care organizations, they're constantly evolving, aren't they? Driven by tech, by market pressures for lower costs, but also for better, more coordinated experiences. But that central management challenge seems persistent. How do you optimize the system, control the costs, without constantly reinforcing that public perception that you're just managing costs, not truly managing care in a way that puts the patient's long-term well-being first? That's the tightrope they have to walk.
It really is. Finding that balance is the ongoing challenge.
If you enjoyed this audiobook summary, please take a moment to hit the like button, share this video, and subscribe to our channel. Your support is what helps us create more great content.